Take a good look at your fingernails. Go ahead, right now, because there are clinically documented changes that show up in the fingernails of people with advanced kidney disease. Real findings, named in medical literature, the kind a kidney doctor looks for on physical exam. But here is what almost no one tells you. By the time those changes appear, the window to act has already closed. The nails are not a warning system, they are a receipt. A research review published in the Archives of Internal Medicine traced that finding back to a 1967 study by Dr. Philip Lindsay, who examined 1,500 patients and found the distinctive nail change, the one that now bears his name, appearing almost exclusively in people with advanced, long-standing kidney damage. Subsequent literature has since documented it in up to 40% of patients with end-stage kidney disease. 40%. And in a 2023 to 2024 cross-sectional study tracking nail changes by kidney stage, the finding was significantly more common in stage 5 than in stage 3, and absent entirely in stage 1, which means by the time the fingernail changes, the kidney has already crossed from stage 3 into territory that takes years to cross back, if it crosses back at all. So here's the answer right now before anything else. The test that catches this before the nails ever change is called an eGFR slope. That stands for estimated glomerular filtration rate. It is simply the measure of how much filtering capacity your kidneys have left expressed as a percentage of normal. A single reading tells you where you are today. The slope, the line across 3 or more readings over time, tells you which direction you are moving and how fast. At stage 3, a decline of more than 3 to 4 points per year is not normal aging. It is progression. And a urine test called a UACR, a urine albumin to creatinine ratio, can detect kidney damage at the filter level months to years before the eGFR ever moves. Under 30 is normal. 30 to 300 means damage has already started. That is the headline. But the name alone will not protect you, because whether the slope is yours to worry about and what you do about it depends on something your last visit almost certainly did not cover. You are in one of two situations right now. Either your kidneys have been stable long enough that the slope is flat, the decline you have matches normal aging, about 1 point per year, nothing alarming, or your kidneys have been moving faster than that and nobody has plotted the line, which means you genuinely do not know which situation you are in. You cannot tell from how you feel. You cannot tell from your nails. The only way to find out is to keep watching. By the end of this hour, you will know exactly what those nail findings mean and when they actually appear. You will know the one monitoring combination that catches decline before any sign arrives. And you will have the exact sentence, the words to say out loud, that gets both of those things tracked on your chart at your next appointment. If you have your last kidney labs written down, get them now. If not, picture the number your kidney doctor or your primary care doctor read off the last time. You are going to need it. You know the room. A clinic off Route 41, somewhere near Fort Myers, maybe further up toward the villages, doesn't matter. A Tuesday afternoon in a waiting room with outdated magazines and a fish tank. He's been in practice a long time. He knows kidney disease. He is not bad at his job. The printout slides across the desk. He glances at the eGFR 41. And then back to the screen, and he says, "That's about what we'd expect at your stage." And he's already reaching for the door. And somewhere in the back of your mind, a question forms, the one you did not have words for. Something like, but is it staying there or is it moving? You don't say it because you don't have the words yet. So you drive home on I-75, and that night the question comes back. By the end of this hour, you will have the words. There are 3 kinds of people watching this right now, and they all need something slightly different from it. The first is someone who got a result, maybe stage 3, maybe just your kidneys are a little off, and has spent the last few weeks trying to figure out how seriously to take it. They feel completely fine. Their doctor seemed unconcerned, but something about the number stuck. What they need is not reassurance. What they need is a precise understanding of what stage 3 actually means, and why feeling fine is not the same as being stable. The second is someone who has been managing a kidney number for a year or more. Labs every 6 months, maybe a medication, maybe a diet change, and the number has still moved. They are frustrated. They are doing what they were told. What they need is the specific explanation for why standard management does not always catch slope changes early enough, and what they can add to the conversation at their next appointment. The third is someone who already has a handle on their monitoring, but is here to understand the mechanism, why the kidneys hide their decline, what the fingernails actually signal and when, and whether there is one refinement they have not tried. What they need is the physiology, clearly laid out with one new thing at the end worth bringing up. No matter which of the three you are, the mechanism underneath is the same. And it starts with something that happened in a kidney clinic near Fort Myers 18 months before a man noticed the first change in his nails. He was in his mid-60s, blood pressure managed, no diabetes, had a kidney number that had been a little low for a few years, eGFR of 41 the last time he had labs. He felt completely fine. He felt fine the month after that and the month after that. He skipped his 6-month labs because he had a camping trip planned, and then because work picked up, and then because he genuinely felt fine, and it seemed like the kind of thing that could wait. 18 months passed. Then he noticed something at the edge of one of his fingernails, a faint brownish band he hadn't seen before. He went in. The new eGFR was 29. He had crossed from stage 3B to stage 4 in a year and a half, without a single symptom. That is not a cautionary tale about missing appointments, though it is that too. It is a physiology lesson, because what happened in his kidneys over those 18 months, the reason the number moved that far, that fast, with no warning, is exactly what Dr. Lindsay's 1967 study and 60 years of subsequent kidney research have been trying to tell us. And it is the thing a standard 6-month check done without slope tracking and without a urine test is not built to catch. This video is not a diagnosis. What you learn here is for one purpose: a better conversation with your kidney doctor. Bring everything in this video to your kidney team before making any change to your monitoring, your medications, or your habits. Let's start with what the nails are actually telling you and why they have been misread. In 1967, Dr. Philip Lindsay published a study in the Archives of Internal Medicine examining 1,500 patients across a range of systemic diseases. He identified a distinctive nail finding in a small subset, a nail where the lower half, the part closest to the cuticle, was pale or white, and the upper portion toward the tip had turned a reddish brown. A clean, horizontal line divided them. He called it the half-and-half nail. We call it Lindsay's nail now. He found it almost exclusively in people with chronic kidney disease. Out of the 25 patients who had the finding, 24 had renal disease. The pathophysiology is not fully settled, but the leading explanation involves two things happening at the same time: reduced blood flow to the vessels near the base of the nail, which bleaches that section white, and a buildup of uremic toxins, waste products that healthy kidneys clear, that stimulates pigment-producing cells in the nail matrix, darkening the tip. The nail, in other words, is picking up what the blood is carrying. And by the time it is carrying enough waste and running enough low on circulation to change the color of a fingernail, the kidney has been struggling for a very long time. That 2023 to 2024 cross-sectional study confirmed what clinicians have suspected for decades. Half-and-half nails showed up in 17 of the stage 5 patients in the cohort. They showed up in 6 of the stage 3 patients, and in none of the stage 1 patients. The statistical association with end-stage kidney disease was significant. The pattern is consistent. These nails concentrate at the far end of the disease curve, not at the beginning. Dr. Lindsay's finding is the most kidney-specific of the nail changes. But there are 2 others worth naming because they sometimes appear in the same conversation and the distinctions matter. Dr. Robert Terry described a different nail pattern in The Lancet in 1954, a nail where roughly 80% of the nail bed is white, with a narrow pink or brown band at the very tip. Terry's nails are less specific to kidney disease. They appear in cirrhosis, in chronic heart failure, in advanced diabetes, in very elderly patients. If your doctor mentions Terry's nails, kidney disease is one possible explanation among several, not a confirmation. The distinction matters, and any doctor who treats these findings as equivalent is applying a blunter instrument than the evidence supports. Dr. Robert Muirk published a third finding in the British Medical Journal in 1956. Two narrow, parallel white bands running across the nail, with normal pink nail in between, in patients with severe protein loss. Murica observed that the lines appeared only in patients with serum albumin, the main protein in your blood, below 2.2 grams per deciliter. Albumin that low does not happen in stage 3 kidney disease. It happens in nephrotic syndrome, a condition where the kidney is leaking massive amounts of protein into the urine, far beyond what a stage 3 patient would typically experience. Muirca's lines are rare. When they appear, they are a signal of a specific advanced complication, not a general kidney warning. Here is what all three findings have in common. They arrive late. They are not smoke alarms. They are fire reports. By the time they appear, a significant amount of the story has already been written. Which brings us to the one finding the nails cannot show you, and the reason stage 3 is the window that most people don't know they are inside. Your kidneys are built with reserve. Each one contains roughly 1 million tiny filters, structures called nephrons, and they are designed to carry more capacity than you use in a normal day. Think of it as a work crew with extra hands on the schedule. When some of those filters are lost, as happens gradually and silently in CKD, the surviving ones do not slow down. They work harder to cover the gap. They filter more blood per filter. They compensate. And because they compensate so effectively, you feel nothing. No fatigue that couldn't be explained by age, no swelling that couldn't be explained by a long day, no pain, no nail changes, no signal of any kind. The eGFR, that percentage of filtering capacity, can fall from 59 all the way down to 30 over 5 to 10 years, and a person can live through every one of those years feeling completely fine. That is not a failure of the body system. That is the system working exactly as designed. The problem is that by the time the system starts to fail visibly, by the time the fatigue, the swelling, the itching, the nausea, the nail changes arrive, the kidney has already crossed from stage 3 into stage 4, and stage 4 is a much narrower window. The distance from stage 4 to dialysis is measured in years, not decades. Stage 3 has no feeling attached to it. That is the whole point. And here is what the eGFR number on one report cannot tell you. It cannot tell you which direction you are moving or how fast. A single reading is a snapshot. If you had one reading at 52 2 years ago and another reading at 47 today, those two numbers are a line. That line tells you your kidneys declined 5 points in 2 years, 2.5 points per year. Normal aging runs about 1 point per year. That difference is information your next appointment needs. But if nobody has drawn the line across your results, if your chart shows a column of numbers without a calculated slope, that information is sitting right there in front of everyone, unread. The 2024 Clinical Practice Guideline for Chronic Kidney Disease, published by the Kidney Disease Improving Global Outcomes Group, KDIGO, and co-chaired by Dr. Adira Levin of the University of British Columbia, published in Kidney International in 2024, specifically recommends monitoring CKD progression at least annually using both eGFR and UACR together. The guideline also notes that a change in eGFR of more than 20% on a subsequent test exceeds expected variability and warrants evaluation. That is the dual standard, two numbers, tracked over time, not a single number pulled from a single draw. And the guideline notes that the UACR, the urine albumin to creatinine ratio, the protein test done on a urine sample, is evaluated in only about 1/3 of relevant patients in population studies. 2 out of 3 people who should have this test on their chart do not have it. Now for the UACR itself. The UACR is a simple urine test. One sample, no special preparation required in most cases. It measures a protein called albumin leaking from your blood into your urine. A healthy kidney filter keeps albumin in the blood where it belongs. When the filter is damaged, albumin slips through. The standard ranges. Under 30 milligrams per gram is normal. 30 to 300 is classified as moderate, the A2 category, and it means kidney damage has already started at the filter level. Above 300 is severe. Albumin leaking into the urine is often the first detectable sign of kidney damage. It shows up before the eGFR drops, sometimes by years. And it is not just a signal. The protein itself, as it passes through the tubules on its way to the urine, inflames the surrounding tissue and accelerates scarring. So catching a rising UACR early is not just diagnostics, it is intervention. But here's the thing, neither the eGFR slope nor the UACR appears on your chart automatically. The slope has to be calculated, your results gathered, the line drawn. The UACR has to be specifically ordered, and unless your kidney team has set up a system to do both of those things at every visit, they may not be there. This is not a failure of your doctor's knowledge. It is a structural gap, one we are going to name precisely in a few minutes, and one that has a very specific solution. First, stop for a moment. Look at your last lab report if you have it nearby. Find the eGFR. Now ask yourself, do you have 2 or 3 results from different dates that you could put side by side? If yes, you already have the raw material for your slope. If no, if you have one number and nothing else to compare it to, that is the gap this video is going to help you close. The question sitting at the back of every stage 3 patient's mind is a version of the same thing. If this is true, if the kidneys decline silently for years with no sign, why hasn't my kidney doctor mentioned the slope? Why isn't the UACR showing up on every visit? They know this. Why hasn't anyone told me? The answer is not what most people expect, and it is not a comfortable one. But it is accurate, and accurate is what you need. Your kidney doctor is not withholding the slope from you. They are not unaware that the UACR exists. The KDIGO guideline that recommends both of those things has been available since 2012, updated in 2024, and the nephrologists who treat the most complex kidney patients know it well. The gap is not knowledge. The gap is structure. A typical nephrology visit runs 15 minutes. A primary care appointment where kidney disease is one of 5 problems on the agenda runs less. In that time, a clinician is managing blood pressure, reviewing a medication list, responding to whatever new symptom the patient brought in, and generating documentation that insurance requires. The pattern a well-trained physician runs in that 15 minutes is built to catch the things that most commonly need catching for most patients. It is a triage system, not a research review. And a triage system, by design, responds to what is visibly wrong. A patient sitting across the desk feeling completely fine, with an eGFR in the 40s and no new complaints, does not visually present as someone whose kidneys crossed a slope threshold in the past 6 months. So, the slope check, which takes time to calculate, requires pulling multiple old results and produces a number that may or may not change today's management, is the thing that gets deferred. This is not negligence. It is the rational behavior of a competent clinician operating under structural constraints that were designed for a different era of kidney care. Research moves faster than routine practice. The 17 years between the original KDIGO staging framework in 2012 and the updated guidance in 2024 saw a substantial body of evidence accumulate. The large cohort studies showing that eGFR slope is a better predictor of long-term outcomes than any single eGFR reading. The trials demonstrating that UACR-guided intervention changes the course of disease. That evidence has to travel from published trial to guideline to professional education to updated clinical protocol to the 15-minute appointment you have next Tuesday. That journey takes years. In kidney medicine, the estimate for research findings to reach routine clinical practice runs somewhere between 10 and 17 years. So when your kidney doctor did not plot the slope at your last visit, the explanation is not that they do not care. It is that the system they are working inside has not yet caught up to the standard the evidence now supports. The someone who brings this into the room before the system catches up is you. Not confrontationally, not as a correction, as a participant in your own care. And the way you bring it in is with one specific sentence, which is coming in the next segment, that makes it easy for your doctor to say yes, adds almost nothing to the visit, and puts both the slope and the UACR on your chart where they belong. Now pause for a moment. If you have been watching a kidney number for a year or more, if you have 2 or 3 eGFR readings written down somewhere, picture them in a row. The first number, the second, the third if you have it. Which direction does the line point? Up means improvement, flat means stability, down means decline. And how steep is the angle? That line, not the dot on your most recent lab report, is the diagnosis your next appointment needs to read. The conversation you have at your next appointment has 3 parts. They are short, they are specific, and none of them require you to argue, diagnose yourself, or challenge your doctor's judgment. The first part is the slope request. The sentence is this: I've been tracking my eGFR across visits, and I'd like to understand my rate of change, not just where the number sits today, but how fast it's been moving. Is there any way we can calculate the slope across my last 3 results and note it in my chart? That is it. That is the whole first part. You are not asking for a new medication. You are not disputing the last result. You are asking for a calculation your doctor can run in 2 minutes using numbers that are already in the system, and asking that the result be documented so it travels with you. Your doctor will respond in one of 3 ways. They may already be tracking it, in which case they will show you the trend line and you will have exactly what you came for. They may be willing to calculate it now, in which case you will have the answer before you leave the room. Or they may say they do not have time at this visit, in which case the right move is to ask whether a nurse or a medical assistant can pull the last 3 eGFR values before you check out, so you can calculate it yourself. 3 numbers, subtract, divide by the number of months between them. You do not need a medical degree to plot your own slope. The second part is the UACR request. The sentence is this: I've read that the KDIGO 2024 guidelines recommend tracking both eGFR and a urine albumin to creatinine ratio, a UACR, at least once a year for people with CKD. Do we have a recent UACR on file? If not, can we add that to today's orders? The UACR, urine albumin to creatinine ratio, is a urine test. In most cases, it requires nothing more than a urine sample collected on the morning of your visit, or at a lab the same day. It is not expensive. It is not invasive. And if the answer comes back under 30, you have a baseline. If it comes back between 30 and 300, that is information that changes what your doctor monitors, and possibly what they prescribe. If it comes back above 300, that is information that may change your treatment today. Again, your doctor will respond in one of 3 ways. They may already have a recent one, in which case you will look at the number together. They may order it, in which case it gets added to your next lab draw. Or they may not be certain it is indicated at your stage, in which case the right response is not to argue, but to note that you have read the KDIGO guideline recommendation and ask whether they would be comfortable including it as a baseline, even if they believe it is unlikely to show anything. The third part is the keystone move. It is the one that makes everything else stick. After the slope is calculated and the UACR is ordered, the sentence is this: Would you be comfortable noting in my chart the last 3 eGFR readings and the trend between them, and whether we have a UACR on record, so that both are part of my longitudinal record going forward? Longitudinal record. Those 2 words are the key. A result documented once is a snapshot. A result documented as part of a longitudinal record, a deliberate, tracked trend, is a pattern. A pattern is what a kidney doctor can act on. A pattern is what travels with you if you see a different physician, move to a new city, end up in an urgent care visit with a doctor who has never met you. The slope and the UACR, noted in your chart as a tracked pair, become a clinical story that follows you rather than a scattered list of numbers that requires excavation. Do not argue. Do not push if your doctor declines. Do not threaten to switch doctors. If the slope calculation is deferred, do it yourself. If the UACR is not ordered this visit, ask again at the next one. The goal is not to win a negotiation. The goal is to get 2 numbers on your chart, in writing with the date. That is all. One more thing to bring to that appointment, and it is the one the previous visit in that Fort Myers clinic left off the list. Ask whether any medications you are currently taking could be affecting your kidney function, and whether your pain relief choices, particularly any over-the-counter anti-inflammatory like ibuprofen or naproxen, should be reconsidered given your current eGFR. You do not need to name a medication to stop. You are asking your doctor to review the list and flag anything that might be contributing to the slope. That is a clinical judgment that belongs with them. Routing it through them is the right move, and the right sentence to do it is there anything on my current medication list that you'd want to revisit given where my eGFR is sitting now? This video is not a diagnosis and nothing here is a medical instruction. Do not change, stop, start, or modify any medication based on what you learn in this video. The goal of every conversation we have built here is one thing: a better appointment with a doctor who is now working from two numbers instead of one, and who has both on your chart where they belong. Now picture two futures. Both of them start today. In the first one, you close this video and you do not write anything down. The appointment comes around in 4 months or 6 or whenever the calendar lands. You sit in the chair, the EGFR is read off the report. It has moved a few points, maybe 2, maybe 5. The doctor says it is about what you would expect. You nod, you drive home. And somewhere between here and the next result, the window narrows a little more and no one has measured how fast. In the second one, you write down 3 things before you close this video. The first is the slope request sentence. The second is the UACR request sentence. The third is the keystone, the longitudinal record request. You put them somewhere you will find them. A note in your phone, a piece of paper in the same folder where you keep your labs. The appointment comes around. You walk in with those 3 sentences. The slope gets calculated. The UACR gets ordered. Both go on the chart. And when you walk out, the doctor is no longer tracking a dot. She is tracking a line with your name on it and a direction and a speed. The man who sat in that Fort Myers clinic and drove home on I-75 with an EGFR of 29, the one who had been at 41 18 months earlier, did not get back to stage 3B. That is not how kidney function works. Lost filters do not regenerate. What he did get was a slope, finally, and a UACR, and a treatment plan that was calibrated to where his kidneys actually were instead of where they had been. The window had narrowed, but it had not closed. Your window is still open. You are in stage 3. You feel fine. That is the whole point of this hour. That feeling fine is not the same as being stable, and being stable is something you can confirm, document, and protect. The nails that you looked at the start of this video, they look the same as they always have. They are supposed to. The window is still open because you have not crossed yet, and you now have the words to make sure that crossing, if it happens on a tracked slope with a UACR on file and an appointment that reads the line instead of the dot. There are 5 questions that people in your situation search for after a video like this one. Here are the honest answers. The first question is, what exactly do Lindsay's nails look like? And how do I know if I have them? Lindsay's nails, also called half and half nails, are characterized by a horizontal division across the nail bed. The lower half, near the cuticle, appears pale or white, and the upper half, toward the tip, appears reddish-brown or tan. The line between them is typically sharp. The discoloration does not fade when you press on the nail. This is different from a bruise under the nail, which is usually dark and localized, and different from normal aging changes, which tend to be more diffuse. If you are in stage 3 CKD and your nails look normal, they are supposed to. These changes concentrate in stage 5 and end-stage disease. If you are concerned about a specific nail change, bring it to your doctor's attention. Do not diagnose yourself from a video description. The second question is, my EGFR has been stable for 2 years. Does the slope still matter? Yes. A stable slope across 2 years of readings is actually the most useful piece of information you can have because it establishes a baseline rate of change. Normal kidney aging runs about 1 point per year. If your slope shows 2 years of stability within that range, your doctor now has evidence that your current management is working. That evidence belongs on your chart explicitly, not just implied by a series of similar numbers. The slope request is not only for people who are declining, it is for everyone whose kidneys are doing something in time, which is everyone. The third question is, I asked for a UACR at my last appointment, and my doctor said it wasn't necessary. What do I do? You do not need to argue the point. What you can do is ask one follow-up question. Would you be comfortable noting in my chart that I asked about the UACR today and what we decided, so there's a record of the conversation? That question does 2 things. It documents that you asked, and it gives your doctor an opportunity to note the clinical reasoning for not ordering it. If the reasoning is specific, your UACR was checked last year and was normal, or your presentation does not warrant it at this stage, that is a clinical judgment you can respect. If the answer is more general, the note on the chart creates a record that the conversation happened, which means at the next visit it is easier to revisit. This video is not a diagnosis. Bring what you learn here to your kidney doctor. The goal is a better conversation, not a self-diagnosis and not a confrontation. Whatever you learn here, route it through your kidney team before drawing any conclusion about your own situation. The fourth question is, what is the kidney failure risk equation, and should I ask my doctor about it? The kidney failure risk equation, sometimes called the KFRE, is a validated tool that uses four variables: your age, your sex, your EGFR, and your UACR, to estimate the probability that your kidneys will reach failure within 2 years or 5 years. It was developed and validated across large international patient cohorts and is referenced in nephrology guidelines. The reason it matters to this conversation is that it requires a UACR to run. Without the UACR, the risk estimate is incomplete. If your doctor has access to it and your UACR is on file, you can ask, based on my current EGFR and UACR, what does my 2-year and 5-year risk look like on the KFRE? That is a specific, answerable question that most nephrologists can respond to directly. It is not a question to ask without the UACR in hand first. The fifth question is, why is Dr. Elizabeth Blackwell telling me this? What's the angle? That is a fair question, and it deserves a direct answer. The angle is this: the people who come to this channel are stage 3 CKD patients who feel fine and have been told their numbers are about what we'd expect. Most of them have never had a slope calculated or a UACR ordered. Most of them have a nephrologist or a primary care physician they trust who is doing their job competently, and who is also working inside a 15-minute appointment structure that was not designed to do everything the current evidence supports. The gap between what the evidence supports and what the appointment delivers is real, and it is structural, and it belongs to nobody and everybody at the same time. The channel exists to give the viewer the one piece of information that closes that gap from their side of the desk. The sentence, the chart request, the 2 numbers, that is the whole offer. No program, no supplement, no paid consultation, just the words. What the nail findings taught the research community is a principle that runs through all of kidney medicine. The visible signs arrive after the damage. Not because the body is poorly designed, because the body is remarkably good at compensating for quiet loss. The kidneys are not the only organ that works this way. Blood pressure rises silently, protein leaks silently, acid builds in the blood silently, bone mineral changes silently. The pattern across all of CKD is the same. The compensating system holds and holds and holds, and the warning signs appear late when the slack has run out. The skill this hour tried to hand you is not specific to nails or to the slope or to the UACR. It is the habit of reading a number across time rather than in isolation. Any number on your kidney panel, your EGFR, your UACR, your hemoglobin, your bicarbonate, your phosphorus, has more information in the direction it is moving than in the single value it sits at today. The slope is the diagnosis. The slope is always the diagnosis, and the only way to see a slope is to collect the points. You will leave other appointments with other numbers. Some of them will sound fine. Some of them will sound alarming. In every case, the question that matters is not just, where is this number today? It is, where was it 6 months ago, and which direction is the line pointing? That question applies to every panel. It applies to every visit. And once you know how to ask it, you will ask it automatically. Not because you are anxious, but because you understand the system well enough to know that the snapshot and the slope are 2 different pieces of information, and that the slope is the one that actually tells the story. That is not a kidney disease skill, that is a healthcare skill, and you can carry it out of this room and hand it to anyone in your life who is sitting in that same chair, looking at a result that seems fine, wondering whether to be worried. The nails never had to change. That is the whole point. Write down those 3 sentences before you close this video. And if there is someone in your life, a sibling, a spouse, a friend, who has a kidney number they have been told is about what we'd expect, share this with them. Not the alarm, the skill, the slope, and the UACR, and the sentence that puts both on the chart. That is the thing worth passing on. The next step, if this hour made you want to look even earlier, before the slope has moved at all, is a video already on this channel about the UACR specifically, what it measures, what the numbers mean, and what the research now says about how early it can detect damage. That video picks up exactly where this one leaves off. The nails never had to change.